I am grateful to APASL for considering me for this prestigious award, and it is my great honor to receive this award from the APASL. I am thankful for my parents for their blessings, my wife for continuous support throughout, and my loving son, and my mentor and guru, Professor Shiv Sareen, for continuous monitoring, motivation, support, guidance, and making me love hepatology. I had my opportunities. My interest in pursuing the career in hepatology was born during my internal medicine days when I had a thesis on clinical profiles and outcomes in patients with liver cirrhosis under the guidance of Professor Y.K. Chawla in PGI Chandigarh. Then I pursued DM in hepatology and currently working as faculty in ILBS under the mentorship of Professor Shiv Sareen. And I am fortunate enough to present my work in the leading liver meetings like ASLD, EASL, UEG, ISG, and the ARC-ACLF consortium. And presently, I am in charge of the Hepatic Hemodynamics Lab at ILBS, Assistant Dean in the APASL School of Hepatology, and was the recipient of the National Scholar Award in UEG. So over a period of time, I developed interest in various fields of hepatology like portal hypertension, natural history of cirrhosis, complicated ascites, AKI in cirrhosis, ACLF, clinical methods in hepatology, and the viral hepatitis. At ILPS, we do close to 1,500 HVPGs per year and close to 1,000 transjugular liver biopsies per year. Based on our work at our hemodynamic lab, we try to define the high risk compensated cirrhosis, which include those patients which have the very high risk of clinical decompensation. And we found that the HVPG more than 20 is a high risk of clinical decompensation. Moreover, we also observed that the many patients with decompensated liver cirrhosis have HVPG of less than 10. And, and we try to redefine the definition of clinically significant portal hypertension. And as per our observation, the HVPG more than 8 is a better determinant of clinically significant portal hypertension as compared to 10. Then, as we know that the simvastatin is helpful in preventing the rebleeding in bleeders as well as preventing the mortality in cirrhotics. But our study from the observation from the hemodynamic lab, the addition of simvastatin to carvedilol does not improve the hemodynamic response in patients who had carvedilol was used for primary prophylaxis of varicose bleed. Then the HUPG was found to be important in preventing the second decompensation in patients who had the first decompensation of cirrhosis. So baseline HUPG not only predicts the first decompensation, but also predicts the further and subsequent decompensation in a patient with liver cirrhosis. Moreover, we found that the liver stiffness as an alternative to the HVPG or in combination, the liver stiffness measurement more than 22 kilopascal can predict the decompensation and need for beta blocker therapy in compensated cirrhosis. Um, we try to define the patients who are having difficult to treat spontaneous bacterial peritonitis, and these patients have a very high risk of liver related complications and mortality. So this includes the patient with hospital-acquired infections, the patients who had the antibiotic resistance, mainly the extended spectrum beta-lactamases, the failed prophylaxis for spontaneous bacterial peritonitis, as well as the patient who had this SBP recurrence and the persistence of SBP despite the antibiotic therapy. So we defined the term difficult to treat SBP for this group of patients. They have the very high risk of treatment failure and mortality. Then our another area of research was on hepatic hydrothorax. We found that the tips when done for the refractory hydrothorax had the modest efficacy. It prevented TAPS in 50% of the patient, hydrothorax resolution in 20%, but it was associated with very high mortality of in the tune of 40% at 6 months. So TIPS is not a good option, very good option for hepatic hydrothorax as compared to refractory ascites where the TIPS is good for preventing the complications as well as mortality. Then one of the major research area of in the last 3 to 4 years is the use of terlipressin for AKI in patient with ACLF. We published the first study on the ACLF AKI HRS, and we found that the terlipressin has the efficacy in terms of reversal of HRS in around 39% of the patient. Then subsequent studies from our group have shown the terlipressin to be superior as compared to noradrenaline in HRS AKI in patient with ACLF. Then the last year, we did a randomized controlled trial in patients with ACLF and AKI. Instead of waiting for 48 hours of volume repletion and starting the terlipressin, we used the early terlipressin therapy at 12 hours of resuscitation, and we found that the early use of terlipressin at 12 hours not only improves the AKI, it improves the AKI at the tune of 68% reversal at day 7 as compared to 37% reversal when used terlipressin in the standard time. And early terlipressin also improves the MAP, urine output, regression of ACLF grade, and thereby improving the mortality. So early terlipressin, as per our observation, should be used in patients with severe liver disease such as ACLF. Then we published. I'm thankful for my colleagues and my seniors, especially my mentor, Professor Sarin, which help us to publish the largest series of liver abscess in the world. We enrolled on 1,600 patients with liver abscess and defined their natural history and progression and management protocols. Then it is always a dream to publish in New England Journal of Medicine. I am fortunate enough to had the 3 publications in New England Journal of Medicine in last 5 years. Then at ILBS we conduct a uh, drills meeting, which is a case-based discussion, decision, reasoning, innovations, and learning in liver disease, which involves the fellows and the young faculty, and it is attended by 800 to 1,000 doctors across the India, and we have been organizing this meeting for last 4 years on a yearly basis. And some of the experts of these meetings include Professor Kamath, Dr. Rocky, Dr. Rela, Dr. Mens, and Dr. Pagarse Pagan. So all innovative personnel are involved in these meetings. Now I have my practical challenges in treat when I treat the patient with liver cirrhosis. We lack the practical practice guidelines for evaluation, diagnosis, and management of liver disease in the resource constrained setting because many patients cannot afford the uh, the uh, the the treatment for liver disease, like the cost of albumin, cost of antibiotics, and cost of the high-end procedures. And we need the state-funded treatment-based research with meaningful clinical endpoints. And more emphasis, I think, should be made on the patient-oriented and algorithmic approaches and clinical methods in the scientific meetings like the APSL and the national conferences across the Asia. And access to health education and strategies to prevent the liver disease progression. So finally, we are doing an ongoing prospective trial on treating the patients who are current of hepatitis, chronic hepatitis B, who are currently not considered treatment worthy, like the patient with chronic hepatitis B with no significant fibrosis, normal ALT, low DNA. We seek to find whether the early therapy or approach all with tenofovir, which is quite safe antiviral drug, can prevent the outcomes in patients with chronic hepatitis B. So thank you again for the APSL for giving me the award, and it's my honor. Thank you very much.